happy to answer questions and make it interactive. So if you have a question, just feel free to ask, because that's kind of how I set this up, as a sort of more of an open discussion than a formal talk. A couple of things I hope to answer is why do we need oxygen in general? When do we consider oxygen to be deficient? So who basically needs oxygen? And then when do we actually need that oxygen that your doctor says that you need? Just one caveat is that in terms of data, so hard data from scientific studies, there really is none, both in general for pulmonary disease and specifically in patients with GAD. And most of the data that I'm going to discuss in terms of where studies have actually been done that are on a relatively large scale, where there has been some form of control arm, have been done in COPD, so in people with emphysema and chronic bronchitis, who are similar to patients with GAD in that they have obstructive type of lung disease. But again, this may, all the stuff that we base this on is done particularly on two studies that were already sort of done in the late 1980s. And in fact, in COPD patients, there's a very large study at the NIH that's going on right now where they're actually re-evaluating some of this data, particularly in certain groups of patients. So what I'm going to show you is not necessarily, it's not the Holy Grail, it's open to interpretation, and a lot of it, as I'll try and show you, depends on sort of interaction with the patients and seeing what the patients want and what we feel is optimal for the patients. So in terms of the overview of the few slides that I have, the first thing I'm going to discuss is hypoxemia, which means low blood oxygen. And here I'm going to try and address why do we need oxygen and when do we consider it to be low or deficient. We're going to talk a little bit about the clinical approach to hypoxemia. So what does some of the data show? What are we thinking when we get your numbers? And then there's sort of four groups of patients that we kind of look at. And again, this is straight out of the COPD literature in terms of how to approach hypoxemia. And then I'm happy to throw it open for a discussion if you have questions on, say, oxygen with travel or certain types of devices. We can discuss that as well. So I want to start out with hypoxemia. And what hypoxemia means is low blood oxygen. And mechanistically, there are a number of causes, and some of these are active in lab and some aren't. But the reason that oxygen is so important is because all human metabolism, or almost all human metabolism, is dependent on oxygen. So whether you eat carbohydrate or fat or protein, if you get down to a chemical level, all of those need oxygen to basically be combusted, to be burnt. Just like when a fire burns, same thing. It's the exact same reaction. And with that oxygen, with that combustion, comes the production of energy, which takes various forms in the human body. And with that energy, you're able to function. Your muscles work using that energy, and you're able to perform other metabolic tasks. So oxygen is absolutely essential, and without oxygen, you simply cannot function at a chemical level. So that's why oxygen is important. In terms of deficiency of oxygen in the blood, we look at this in one of two ways, and I'm sure a lot of you will have had either an arterial blood gas, the ABG, which is where we get a blood test from your artery, and we look at the amount of oxygen in there. And in that, we're particularly interested in what's called the partial pressure of oxygen. So it's literally the pressure of oxygen in your blood, okay, and that we measure in millimeters of mercury. The other way that is more common is to look at the percent saturation of hemoglobin. So hemoglobin is the protein in the blood that carries the majority of the oxygen, and the oxygen will bind to there, and you can have oxygen bind all the way up to 100%. Saturated is the word we use. It basically means all the sites for oxygen binding are occupied. So the hemoglobin is 100% saturated. And this can be done using the pulse oximeters that, I'm sure you've all seen. There are very many different kinds, but they usually fit over your finger. Sometimes they're placed on the forehead or even the ear. And it's usually done at rest and with exertion. So the 6-minute walk, I don't know if any of you have had 6-minute walk tests. That's something that we routinely get on all our patients, at least at the first visit. And so what they'll do is they'll check it when you're resting, and then they'll walk you for 6 minutes. And that's useful information to us because it gives us both an idea of what kind of distance you can do, as well as what happens with your oxygen during that exertion. And then in terms of what is considered hypoxemia, so we'll discuss some numbers when we get into the more specific, the different types of groups of patients. And these numbers come from the studies. So these studies set criteria, and that's what Medicaid and Medicare, and in certain cases Medicaid, have adopted as their numbers. So when you see something that says, Medicaid or Medicare will pay for the oxygen versus not paying for it, these are based on the numbers from the study. But what we consider to be clinically significant low oxygen is when on the blood gas, your oxygen is less than 60, okay, or your percent saturation of hemoglobin drops below 90. That's considered low, okay? But you'll see these numbers are a little bit different from what we're going to discuss. And that's because, like I said, the studies were set up with different numbers, and that's where the data is. Yes?
Is that percent below 90 at rest or during exercise?
So it could be both. And we'll discuss both of those groups of patients because the data is very different in those groups of patients. So what we do is we look at it first at rest, and then we look at it with exertion. You can actually do the same thing with a blood gas, but because it's not a pleasant test to have, we try and stay away from that. So it's not like getting venous blood drawn. It's a little bit more painful. Yeah, it depends. It's definitely more painful. I won't argue with that. I have some patients who don't mind it, but I would say the majority would prefer not to have it done. And that's why we usually get it once as a baseline, and then we're done unless there's something that we really need to do with it. I'm going to go through and we'll go through the sort of, if you look, I'll go to the next slide, but the important word here is resting, because there's both exertion, which I'll get to, and resting, and the data differ. Yes?
My question is, and I'm just going to use my case as an example because I'm kind of going through this. How quickly do those numbers change? Because, for example, during the morning, I'm great, fine, dandy, but then in the afternoon, I'm at the point of passing out. So could my numbers change if I go to the afternoon and have a blood gas drawn, or have my 6-minute walk during the afternoon?
So the answer is they change all the time, but they change a relatively small amount. And they'll usually fluctuate throughout the day. One of the problems we have at our medical center is it's like most medical centers these days, it's 6 or 7 city blocks. And so the patients are parking relatively far away from where they come in. And so we like to make sure we get them in and they get a chance just to re-equilibrate and take some rest. In your situation, if they go down significantly at certain times of the day, that's not something that's very typical that we see all the time. But we do know they vary throughout the day, just usually not to the point where you would be completely normal in the morning and completely low in the afternoon. But that's something that we need to take into consideration. So in that case, we may actually want to get it during the bad time so that we know what the sort of the minimum is. Because the maximum, if it's normal, is going to be less helpful to us than knowing what the minimum is.
I just want to make sure I understand that you're saying that the saturation and what you're measuring with the arterial
pressure,
they positively correlate.
They do.
One would show a down reading, one would be okay.
They do positively correlate. It's a little bit more complicated than that. Generally, the lower your oxygen saturation, the lower your PaO2, so your partial pressure of oxygen. It becomes a little more complicated because The mathematical relationship is different. So with the oxygen, it's more of a linear relationship with the gas pressure. With the percentage saturation, it's what we call a sigmoidal relationship. So you can stay stable for quite a while and then you sort of just drop right off. And that's because of the nature of the binding of oxygen to the hemoglobin. But we don't usually get situations where your oxygen saturation is very low and your partial pressure of oxygen is normal. There are certain pathological conditions like carbon monoxide poisoning where that can happen, but if those things are not an issue, they will correlate. But for example, somebody may have a PO2 of 60 and a saturation of 93, and somebody else may have a saturation of 90 and a PaO2 of 70. So there's going to be some variation between patients and even within an individual. But as a rule, the one's not going to be normal and the other one very low. They will run with each other pretty close.
So if you would be on the border, like, I've never had an arterial test, and so it's always been the oximeter. If you're kind of like on the border that way, you're not qualifying for oxygen from your insurance company. If you're not getting the reading you need, perhaps you would by having the blood gas done.
Yeah, it just depends. That could go either way. In my experience, the blood gas would probably be okay in that situation because of the way the relationship works. And again, like I'm going to show you, there's not a lot of good data, so it's not something to necessarily be worried about if you're on that borderline, on that cusp. So I want to start with this group because this is the group where there's really not a lot of controversy. So what's defined as severe and resting hypoxemia is in somebody who is at rest, who is not currently short of breath because they just walked somewhere or did some activity. If your PaO2, so that stands for the arterial pressure, the P is the pressure, the A is the arterial, oxygen in your blood is less than 55. Okay, if your resting oxygen saturation is less than or equal to 88, so 88 or less, or if you have a resting PaO2 of 56 to 59, so a little bit higher, but there's evidence of what we consider end organ dysfunction. So if you have heart failure, if you have pulmonary hypertension, if your hemoglobin is low oxygen makes your hemoglobin go up considerably. So if your hemoglobin has gone up to a high level, we consider these to be significant even though the oxygen is not as low as other patients. In these cases, what's been shown is that, and this is again mainly in patients with COPD, that oxygen therapy improves survival. And the data seems to suggest that it should be worn 24 hours a day, 7 days a week, 365 days a year. Okay? So in this situation, there's very little controversy. Everybody will give oxygen. And this is the numbers that the insurance company wants to see to actually pay for that oxygen. Okay? Any questions on this? Yes?
Do they allow other factors into this, for example, weight, other issues like arthritis?
Not usually. The problem is so we might look at other factors, but in terms of insurance coverage, they're looking at strictly this kind of data, the data from the studies. So we will take other things into consideration, but we're not going to get that covered unless you meet these criteria.
Black or white on those numbers.
Pretty much. I mean, we can work with them in certain situations, but yeah, they're not going to approve anything but this unless we give them other reasons.
So in COPD patients, it's well documented that if your O2 is 88 below, there's a survival benefit.
With oxygen, yeah.
Right. Has this been proven in my patients, or are we extrapolating?
We're extrapolating. Okay. And with very minor exceptions, we're extrapolating to every other pulmonary disease. Okay. And these survival benefits can be very small, real but small. And with small patient populations, you have a very, very difficult time proving this, especially in a controlled fashion. Because when you've got to do a controlled study, sometimes we're randomized 2 to 1. So if, you need at least an extra third of patients for that control arm. And in these days, if you don't do a controlled study, no one's going to publish it. And so it's difficult in patients with LAM, because there are a lot of patients who don't even need oxygen. So you sort of narrow down the group to the point where you're looking at such small number of individuals. So at this point, the data is extrapolated for most pulmonary diseases.
By control, you mean double-blind study?
Yeah, so it would be hard to blind it.
Right.
You could, there are ways you could do it. You could give air through the cannula, but yeah, it's a numbers game more than blinding it versus not blinding.
I have a question.
Yes.
So insurance is really just interested in survival, not quality of life.
Well, I think you can generalize that for insurance in general, yeah. I don't think I mean, I'm not going to defend the insurance companies. So, yeah, and that's something we'll get to on some of the next slides is there's a specific group where there's very little data, and there I think, at the end of the day, it's all about quality of life for patients. It's nice to prolong survival, but at the end of the day, you want people to be comfortable. And I agree with that completely. But yeah, in my experience, if there's no positive benefit in terms of survival, or if you can, the one thing they really like is if you can show them that you can save some money, they'll jump all over that no matter what the patients feel. But, it's just the way of the world, unfortunately.
But it's like, they're happy if we just sit on our couch all day long and do nothing, but just breathe.
Well, and I think, I've met a lot of the clinic directors here. I think most of us would fight for our patients if we need to. There are some people that definitely benefit from oxygen, and there are ways to get oxygen if you need it. What I'm more interested in is from our point of view is what's important and what the data shows, which there's not a lot of data. But, if we feel somebody will benefit either from a survival standpoint or a quality of life standpoint, we're going to make sure they get that oxygen. But yeah, I don't necessarily think that's everybody's goal.
Does Medicare run by the same numbers?
There may be state exceptions or regional exceptions, but as a rule, yeah, these are the numbers that they're looking for. So the other group is the patients with what we would consider to be sort of moderate hypoxemia. So these are people with a resting, and again, this is resting, oxygen pressure of greater than 56, or a resting oxygen saturation of 89 or greater. And in these patients, there is no survival benefit, at least in the studies that have been done up till now, mainly in COPD patients. And to answer your question, there's no consistent evidence that other outcomes are improved. And some of the things they've looked at are quality of life. There are studies that show some benefit. There's some studies that don't show benefit. Symptom scores. So this is essentially like a more objective way of trying to look at quality of life. So do the patients experience less shortness of breath at rest, or with exertion, or during activities that they do throughout the day? And interestingly enough, at least in COPD patients, there was one study that actually showed there was no difference in the patients dropping their oxygen throughout the day, either at rest or with exertion. So even with the extra oxygen, some of these patients still became hypoxemic throughout the day. So there's no real evidence at this point to suggest that these patients will benefit other than perhaps in quality of life in some studies. The third group that I want to talk about is the group that becomes hypoxemic overnight. And I don't know if some of you know about sleep apnea. Sleep apnea is a separate entity that anybody can have, whether you have pulmonary disease or no pulmonary disease. I'm not talking about those group of patients here. I'm talking about patients in general with lung disease, and this has been shown for a number of different lung diseases, can develop low oxygen levels at night, even if their daytime oxygen is adequate. And it's often what we refer to as silent. You don't know what's happening and you don't feel anything. But if you do what's known as an overnight oximetry test, so that's where they do the pulse oximetry overnight, we can demonstrate that some patients get this dip in their oxygen. Now, it's not necessarily to low levels. It's lower than what they are during the daytime. So it may still be in that normal range. It may drop from completely normal to low normal, or it may become actually physiologically low. But this has been described in other lung diseases. And again, in these patients, when they've looked at these patients, there is no survival benefit. And because it's mainly a silent process, so no one knows what's going on, they've shown that other outcomes are not consistently improved. And the outcomes they specifically look at in these situations are things like sleep quality. So do the patients feel more or less rested after a night's sleep? They look primarily at things like the pressure in the pulmonary arteries and heart function. And the reason they do that is we know that with obstructive sleep apnea, where your oxygen goes low, those patients can develop pulmonary hypertension, they can develop cardiac dysfunction in severe cases. And so when they look at this, there's no real difference in any of these outcomes, at least not on a consistent basis. So again, in these patients, we don't really know the answer as to what oxygen, whether it's beneficial, but the data that we have does not show any benefit at this point in time. So the last group I want to discuss is sort of the controversial group, if you will. And I'll discuss, there's sort of a number of options of pursuing this, and I'll tell you what we do. This is controversial for a number of reasons. Okay, so these are patients that we see that when you get a resting blood gas or a resting oxygen saturation, everything looks great. They're fine. But then when we do the 6-minute walk, at some point during that test, their oxygen saturation drops into the range that would qualify them for oxygen at rest. And one of the problems is when this has been studied, everybody has their own definition of hypoxemia. So some people say it has to drop into the abnormal range in their studies. Other people say, well, if it drops by 5% or more, so you could start at 100 and drop to 92, that would be considered hypoxemia. So the target is different. It's a moving target, and so it's very hard to get consistent data if everybody's talking a different language. So that's one of the problems. And so because of this, the decisions for initiating therapy on a sort of physiologic level are kind of complex. So what does the data show in these patients? So there are some studies that show that short term, and we're talking weeks to a few months, that there is an improvement in symptoms. So essentially quality of life gets better for these patients. Things like shortness of breath, exercise tolerance, these have been shown to improve, but these are not long-term studies. None of these went a year, 2 years, 3 years. Long-term, there's just no data. We just don't know the answer. And so there's sort of 3 ways that you can approach this. The first way is you can say, well, you know, there's no good long-term data, so we wouldn't give anybody oxygen. Based on the short-term data, I think that's an unacceptable way of approaching things, because even if we do improve things for a short period of time and that benefit goes away, that's fine as far as I'm concerned. So I think that's not something we even consider. The second is to give people a trial of oxygen. So you say to the patient, why don't we put you on oxygen for a variable amount of time, 1 month, 2 months, even up to 6 months. And let's see how you feel. And if you think it's helping, great. If you don't think it's helping, I'm happy to stop it. I have a fair number of patients, not necessarily LAM patients, who sort of, you know, find oxygen to have a real stigma attached to it. They do not enjoy walking around with a canister or a small concentrator and a nasal cannula, and it's just not acceptable to them. And, you know, so I think in those situations, I try at least encourage them to do a trial, and if they feel better, then, you know, usually they will decide to stick with the oxygen. And our general policy is that we give it to everybody. So, I'm happy if the patient wants to stop for a reason after that, but I encourage anybody who falls into this exercise intolerance group to get the oxygen and to try it. In theory, there are risks to oxygen therapy. What we know is that in certain diseases, there is an imbalance between certain chemicals, free radicals is what we call them, that are generated in the presence of oxygen that can contribute to lung disease. So this is certainly the case in things like emphysema, and there are other diseases. So in theory, oxygen may not be a good idea in these patients. But again, there's no data at all to show that it's detrimental. And I think in a situation like this, even if we don't know that survival is improved, if quality of life is improved, I think that's paramount. So we will make sure that everyone who desaturates with exercise gets oxygen, and we've never had a problem doing that. And so that's generally our approach to oxygen in this specific group of patients. And from what I've discussed with most people, that this is generally the approach, is that these patients are considered to benefit from oxygen, at least symptomatic. So we're sort of open for discussion, but if we've got some time left, I'm happy to answer any more questions that you guys have. If you have questions about air travel and oxygen, we can discuss that as well. Yes.
Can we discuss just what you said?
Okay, so air travel. So when we're dealing with air travel in patients with LAM, it's a little more complicated. And the complication arises with the whole issue of pneumothorax. So one of the things that when you travel, as you go up in altitude, the oxygen content of the air, the pressure drops significantly. And it's the pressure of oxygen in the air that drives oxygen from the air into your lungs. So if that pressure drops, the amount of oxygen literally being pushed across into your lungs, into the blood, will go down. The second thing that happens is the density of the air decreases, and what that means is everything expands. Okay? So air trapped in cysts or bulla is going to expand, and that increases your risk for pneumothorax. So there are certain groups of patients where we discuss air travel, and the issue there is, are you going to need oxygen or are you not going to need oxygen? With LAM patients, the first issue becomes, well, what is your risk for a pneumothorax? Because if you're going to have a pneumothorax, it doesn't matter if you need oxygen or not. And this is sort of a little bit more of a difficult area. In patients who I think have had pneumothoraces and we have a fair number with bilateral pleurodesis, we generally will let these patients fly. If somebody has LAM and cystic lung disease and they have poor lung function, I generally tell those patients it's not a good idea to fly. There's the sort of in-between group where somebody may have not had pneumothorax and have pretty good lung function, or they've had a pneumothorax but not a pleurodesis. For the patients who have had a pneumothorax and no pleurodesis, I would tell them absolutely not. For the other group, it's a little more tricky because they could be fine, they may not. So that's hard to predict. So the first issue we will usually discuss is, should you be flying here? The next issue becomes, well, let's say you're safe to fly, then do you need oxygen or not? And this is kind of complicated. There is some data actually from the British Thoracic Society. The American Thoracic Society hasn't sort of published an official statement other than sort of agreeing with the British Thoracic Society. But there is what they do, there's a test called the high altitude stimulation test. And from what I understand, most places do not do this. And what they do is they start with an oxygen saturation. So this is for people who don't need oxygen without flying. If you need oxygen before you fly, you will need more oxygen when you fly. And so what they do is they start with an oxygen saturation test. If you're 95 and above, they've shown that the chance of you becoming significantly hypoxemic is very low. So generally, you're good to go. If you're less than 92%, you will almost certainly need oxygen. And then what we do is we simulate high altitude by giving you 15.1% oxygen to breathe. Usually the air is 21% oxygen. And based on that, we titrate the amount of oxygen you will need on the plane. And then if you're in that 92 to 95 range, then what we do is we actually put you at that altitude without oxygen. So we put you on 15% and see what happens. And then if you're fine, you're okay. And if you're not, then we can, at that same 15%, titrate. And again, this is not something that we do all the time. So usually what we'll do is, if you need oxygen, we will add 2 to 3 liters of oxygen to your prescription to fly with. And if you're sort of in that borderline group on your regular testing, we will add 2 to 3 liters of oxygen to that. If your oxygen is great, your saturations are great, at baseline we are less concerned. And the reason for this is, excuse me, the plane is pressurized to 8,000 feet. So, and the FAA allows planes to fly to depressurize further to a maximum of 10,000 feet in a case of an emergency. Where you're really flying at is anywhere from 36 to 40,000 feet. So it's the equivalent of being sort of between Denver and the highest mountains in Denver. Denver is like, what, about 5,000 feet, and those mountains are 14,000 feet. So, you know, people who live in Denver and are doing fine are a lot more likely to tolerate flying than somebody at sea level, because the lower down you go, the greater that pressure, partial pressure of oxygen is.
So when you say that 20% is normal and 15 is pretty much high elevation, what is your actual elevation difference? Because I do live at elevation, I live at 4,600, and I recreate above 8,000 feet. So at what point do you think that, because I do need oxygen at home, I don't need it here, but I do need it at home for exercise. And I need it just at rest when I go to high elevation.
So I'm not sure. So I'm not sure what you're asking.
When at what elevation does that drop?
Oh, so that will depend on what happens with you. So it's essentially an almost linear relationship as you go up. But somebody whose oxygen saturations at sea level are, say, 92% will need oxygen lower down than somebody who are, say, 100% at sea level. So there's no magic number at which everybody's going to need oxygen. It depends on what your baseline requirements are that will determine at which altitude you become hypoxemic. So there's no number. The only reason we use the 15% is because they've worked out that simulates the amount of oxygen in the cabin at a pressure of 8,000 feet, which is what the cockpit is pressurized.
Is there a high altitude test that goes higher than 8,000 feet?
No, and like I say, the reason is because they will pressurize to 8,000 feet. In emergencies, they're allowed to depressurize to 10,000, but strictly speaking, they pressurize to between 5,000 and 8,000. We go with 8,000 because in theory that's the worst case scenario. But depending on the plane and what altitude it flies at, they may actually be pressurized to 6,000 feet. So if we do 8,000, that's the maximum non-emergency allowed depressurization that they're allowed in the cabin.
So what she ran into was flying on a small plane.
Like a private,
Yeah, so
15
yeah, so I know some of those. I mean, if you're talking about really small planes, like 2-seater planes, and those are generally not pressurized at all. So whatever altitude they're flying at, that's what they're flying at. So I mean, you may, in that situation, if you wanted to be a pilot or something like that, you may be able to do a test in such a way that could be simulated. But again, the issue there would really be an issue of pneumothorax, because like I said, all that, your ears getting blocked on a plane, what that is as you go up, the air in those cavities in your sinuses and in your ears, your inner ear, those expand. And so that pushes out. And then when you land, if there's no blockage, everything equilibrates while you're going up and down. But the sort of pain you have when you land is shrinking now. And there's now a negative pressure that you can't relieve. And the same thing happens in cysts in the lung. So the issue there that I would be most concerned about is a pneumothorax rather than hypoxemia. Because your risk with a pneumothorax, we know that people tolerate hypoxemia very, very, very well. There's some limited data to show that, that patients can go sort of for days to weeks with the kind of oxygen level you experience on a plane, and not have any problems. A lot of this is people who are asymptomatic, and they've shown this. They've shown this in COPD patients who have flown all over. People who fly frequently, their oxygen sits at 80 to 85, and they're just fine. So, in that situation, as your doctor, I'd be much more concerned about a pneumothorax than the side effects of having low oxygen for a few hours.
So then how concerned are you for, say, international flight for pneumothorax?
So the bottom line is, so this is my thinking. My thinking is as follows. I'm as concerned for things happening on every single flight. The risk is the same. Okay. Where the concern exists is if you develop, and I've been in this situation with a medical emergency on a plane. If you developed a pneumothorax flying from here to Los Angeles, they'll just land in Kansas City. If you develop a pneumothorax flying from here to London, there's nowhere to land for a few hours. So I think the risk of something happening does not change. The risk of having something happen and be without medical care for a long period of time. And, I don't want to overemphasize the risk. These are very, very low. So, the risks of all medical emergencies occurring on all flights, if you do it per passenger, not just per flight. So, there's hundreds of passengers on each flight. The risk of having an emergency is like 1 to hundreds of thousands of individual flights. It's low, but the problem is when it happens to you, it's 100%. And so that's more the concern. And when they talk about flying and high risks, there are very few situations that the British Thoracic Society sort of identified as high priority, so people who should really be concerned. But people with LAM was on the list. And it was not hypoxemia, it was pneumothorax that they were concerned.
So are these tests done at just resting levels on the plane?
No, so what we start out with, and we don't even do a lot of this, but it's something that we've looked into, is that to qualify for the high altitude simulation test, you would first get a resting oxygen level. If you're already on oxygen, there's no point because we know you'll need more. And so we can actually do the 15% with your oxygen on and then titrate it up if needed. But yeah, they're done at rest, sitting down without any oxygen on, and then we'll stratify you into the sort of not a problem group, definitely a problem group, and maybe there's a problem group.
Because that doesn't take into consideration trying to walk the concentrator to the bathroom.
So here's...
It's really a problem because you drop so fast. I'm considering diapers next time.
Here's the situation. Somebody actually did a study on this. I think they were from New Zealand. I met them at a conference. It wasn't very well-published study, but people without lung disease who walk to the bathroom on a plane will drop their oxygen saturation. I don't know how low yours gets, but as I mentioned, we know that you can tolerate oxygen in the 80s for hours at a time. Now, you may have symptoms, and that I'm not arguing about. But if you're not going to the bathroom because your number drops, but you're able to get there and back, I would not worry about that too much. If it gets lower than the 80s, you may just need more oxygen. When you do that, you can turn your oxygen up. But if it's in the 80s for a short period of time to get to the bathroom and back, there really is no data to suggest that anything bad is going to happen to you in that 10 minutes. That may be the situation.
Well, I can drop easily into the 70s on 6 pulse. Just going to the restaurant.
So the issue with pulse is we generally do not use pulse,
Yeah.
depending on the system, above 3 to 4 liters because you will have a deficit.
Yeah,
With-
I'm fine sitting.
Yeah.
It's just like getting up to, I always beg to be right by the bathroom. And then I ask somebody to carry the machine.
That's reasonable. I mean, you know, what I would consider doing is if you go to the bathroom, do you have a system that can switch between pulse and flow?
No.
So it's only, so that would be the other option, is to get a system, or just on the plane, take a continuous flow system.
Yeah.
Because at 6 liters, you're definitely not going to get the optimal amount of oxygen with a pulse system.
But the continuous flow systems don't go up higher than 3 or 4, do they?
I'm pretty sure you can get some that can, well, you're using a concentrator.
Yeah, but then if you buy oxygen, you can't even afford to fly.
Yeah, I know, I've run into this problem before. There are concentrators that will go higher, but they're a little less portable. I mean, they're a little bigger, which sounds like it's not really an option for you. So,
Yeah.
yeah, it's difficult.
I
I think if you're not symptomatic, you should be okay.
Yeah.
Why isn't oxygen companies don't haul off of it? And I even had the oxygen company tell me that they don't because it's pricey and that they will never, the company I'm with, they said they will never offer liquid, and that even said that some that are offering it are going to be discontinuing it because it's so pricey.
I think some
Why
of it
is
is,
that?
some of it is, well,
I think it
because
should be universal, everybody should be offered.
the thing is, you know, that if you've got a concentrator, you sort of plug it in, and I know it's not this simple, but you plug it in and it's sort of there and you're done. With the oxygen, one, there's the cost of the processing, of getting it into the tanks. Then they've got to service the tanks. They've got to bring them to your house, take them back. So from their standpoint, it's definitely much more costly and it's much more labor intensive for them. And again, that doesn't mean to say that it's better for patients, but that's sort of the realities that they're facing, whether they're right or wrong. That's, you know, they're unfortunately, they're a business and they're going to do what's better, I suppose, for their bottom line. But convenience and preference aside, you know, oxygen is oxygen. But, you know, I can't stand up here and make an excuse for the companies, but there definitely is a cost involved, both in terms of labor, in terms of materials for them to service a patient with tanks versus putting a concentrator in your home and sort of saying, call us if there's a problem.
Well, yeah, they tell you airline and crew. Well, I just heard it for the first time with my airline and crew. It didn't fit under the seat. I had to unscrew it, take it off its wheels, and then the rack didn't fit up there. So they said, no, we'll have to plane side it. And I'm like, oh, well, plane side you. You know, I mean, it was so irritating. It made it like you were a criminal trying to do you
a lot of it is dependent, some of it's dependent on airlines. I have one patient, she does not have land, but she uses oxygen, and she flies all over the place, all over the time, and literally, depending on the airline, she runs into trouble frequently because every airline's different, and again, we need to get it standardized, but at this point, you know, it's very, very difficult. So usually what we tell people to do is, and sometimes you don't know you're going to travel, but when you do, we tell them, give us at least 2 to 3 weeks notice so that we can fight the fight that we need to do for you in the situation where an airline is obstructing or the company's giving trouble, or, you know, and usually with that amount of lead time, we get it figured out. You know, my nurse is very, very savvy with all this sort of stuff. She actually knows all the bad player airlines and everything, and so somebody will call her and she'll say, oh, you're going to have to call and speak to whatever, and it can be done. But yeah, the best thing is just to, if you can, plan a few weeks ahead, because that'll really save you a lot of trouble when you get to the airport.
Okay, we need to switch now to the next session. So